All right, so good afternoon, everyone. And as promised, I am now uploading the nursing care of clients with chest and lower respiratory tract disorders. So I hope that uh, this afternoon or the time that you will be watching this video, you will prepare your notebooks, okay, your pharmacology books, your medical and surgical books, and you know your notes, your ball pens, okay, and your open and relaxed mind. Okay, so now I am more of the quality of students that I am teaching, okay, rather than the quantity. And I have always been waiting for the time that your environment is silent and you can focus on the medical, surgical, nursing concepts. Okay? So, I believe that it is not easy to understand the medical surgical concepts, especially when you create your own pathophysiology. Okay? And based on our experience with you guys, we have seen that in your sophomore year that you are having so much of a difficulty to understand not only pathophysiology but to correlate what you have learned in anatomy in your biology subjects to your nursing care management subjects or the NCM subjects. And these subjects are very important for you to understand because, okay, these are nursing professional subjects and the board exam is situational. So you have to understand the concepts, in detail. And this is the thing that I would want to emphasize this afternoon or the moment that you are watching this video. So we would have a quality, we would have a pacing, okay, wherein I'd like to believe that you can understand at least, if not the basic, the how the body responds, how the body is working, how respiratory system is working, and how we would take care, okay, the nursing way in relation to clients with chest and lower respiratory tract disorders. It is not as easy as memorizing, okay, but you have to correlate the normal values, okay, the significance, okay, the implications, the medications that should be taken. All right, so this afternoon, okay, we will begin with the anatomy. Okay? Let's talk first with the anatomy and physiology of the respiratory system and the assessment of respiratory system. Okay, so as you can see in the picture, that is the pharynx, okay, the epiglottis, the larynx, the bronchus, the left lung, okay, the pleura, the diaphragm, the right lung, the trachea, and the nasal cavity. And on the small circle, that is the bronchiole, okay, the alveolar sacs, and the alveoli. Okay, so you have to understand, class, the anatomy and physiology of the respiratory system, because if you will not understand it, no, the functions of the organs, the functions of cells, the functions of the body parts that is located in your upper respiratory system and in your lower respiratory system until it goes to the lungs, it would be hard for you to understand things. Okay, so the respiratory tract extends from the nose to the alveoli and includes not only the air conducting passages but also the blood supply. Okay, so The primary purpose of the respiratory system is gas exchange. That's why in our nursing problems, if there is an impairment of the gas exchange because the respiratory system is damaged or the lungs are damaged, that's why we say impaired gas exchange, because the primary purpose of the respiratory system is the exchange between the oxygen and the carbon dioxide. Okay, which involves the transfer of oxygen and carbon dioxide between the atmosphere and the blood. Okay, so from the air that we breathe outside of our body, as it goes inside of our body down to our lungs, as it is also transferred or distributed to the systemic, okay, part of the body or to the entire body. Okay, so the respiratory system is divided into two parts: the upper respiratory tract and the lower respiratory tract. Okay, so what are the parts of the upper respiratory tract? Okay, so these are the nose, the pharynx, the larynx, and the trachea. Okay, so upper, meaning to say outside, at the upper portion, at the upper part, the, at the upper tracts, okay, of the respiratory system, ada haibabaw, okay, and in ilong, and in pharynx, larynx, trachea, all right? So functions of the upper respiratory tract includes, okay, so what are the functions of these parts? Okay, the nose, no? So what is the function of the nose? Okay, um, baka tingin ka lang sa nose mo at hindi mo alam what is the function of your nose. So the nose detects odor, molecules, and helps filter and warm the air we inhale. Okay, so ang nose nimo, amo ito nag-filter, kung ha-picture pa, gin-filter han nose ang mga molecules, particles, okay, atoms, okay. The the nose is the one filtering anything that goes inside our respiratory system. Okay? So sa nose pa lang gin-filter na hiya kay bangin poisonous, okay? And then the nose warms the air that we inhale. Okay? So the upper respiratory system or the upper respiratory tract consists of the nose and nasal cavity, the pharynx, and the larynx. So these structures allow us to breathe and speak. So kung may problema ang imo pharynx, may problema ang imo larynx, diri ka nakakaginhawa. Diri ka nakakayakan. Okay? Because amo ito may mga problema ha. Mga cleft palate, no? Yung mga incomplete ang upper respiratory tract. Okay? They are not able to speak and breathe. Alright? So, the nose, the function of the nasal cavity is to warm, moisturize, and filter air entering the body before it reaches the lungs. Kay mamay ka, di ba? Mga polluted air, mga dagko nga particles, dumiretso ka lungs, di mapatay ka agad, no? So, mapupuno agad ang lungs in mga foreign bodies. Okay, so, hairs and mucus lining. Itong mga hairs sa nose, okay, inside the nostrils, right? Hairs and mucus lining the nasal cavity help to trap the dust, mold, pollen, and other environmental contaminants before they can reach the inner portions of the body. Okay, so hindi lang yan, sometimes there are people that doesn't like having their nose being hairy, but those hairs are the ones protecting your lungs, protecting your respiratory system from the dust, mold, pollen, and anything in the environment that may contaminate our respiratory system. Okay? So the function of the nose are olfaction or smelling, respiration, breathing, filtration of foreign particles from inspired air, and humidifying the air. Okay? So the pharynx function, the pharynx respiratory role is mainly to allow inhaled air entering the nasal cavity to make its way to the respiratory tract, which includes the larynx, the trachea or windpipe, and finally the lungs, bronchioles, and alveoli where respiration take place. Okay? So the larynx is the one that protects the airway from choking on material in the throat to regulate the flow of air into the lungs and the production of sounds used for speech phonatory. So you really have to take care of your bodies. You really have to take care of your voices. You really have to take care of your face, your respiratory system, your upper and lower respiratory tract. Because, okay, your larynx, for example, it is the one protecting you from choking. Remember that we eat anything, okay? We eat a lot of foods. And kung waray ka larynx, mag-choke ka. Okay? And then it also regulates the flow of air. Or else, kung waray larynx, madiretso ang hangin ha, aton lungs, we will get drowned of so much air. Okay? And, of course, the production of sounds. So, remember class, upper respiratory tract above, lower respiratory tract below the upper respiratory tract. And in the upper respiratory tract, we have nasal cavity, we have pharynx, and under the pharynx, there are nasopharynx, oropharynx, laryngopharynx, and then your larynx, your trachea, your left and right um, primary bronchi, and in the lower respiratory tract, right pleural cavity, okay, bronchus, mediastinum, diaphragm, left pleural cavity, and the pleural space. Okay, so this is the lower respiratory tract. Okay, so in the lower respiratory tract, that would be the primary bronchus, secondary bronchus, tertiary bronchus, the bronchioles, and then we have the terminal bronchiole, we have pulmonary vein, we also have pulmonary artery, we have the capillary, alveolus, and the alveolar sac. Okay, all right. So the lower respiratory tract, okay, which is our topic, no, for this morning or for this afternoon rather, okay, consists of the bronchi, the bronchioles, alveolar ducts, and alveoli, with the exception of the right and left main stem bronchi. All lower airway structures are contained within the lungs. No? So except sa mainstem bronchi, left and right, lahat ng lower respiratory tract is inside the lungs or within the lungs. Waray lower respiratory tract um, body part na adaha gawas. Adto ito inside of the lungs, okay? Not outside. All right. So what is a bronchi? Okay? Bronchi, okay, what is the function of a bronchi? Is to carry air that is breathed in through to the functional tissues of the lungs. The bronchi and bronchioles are parts of the conduction zone of the respiratory system, allowing the passage of air from the external environment into the lungs, where gaseous exchange can take place. So, class, we would want to reiterate the anatomy and physiology because you have to understand that you're not simply telling the patient about the coughing exercises, the breathing exercises. You have to understand that, the bronchi, carries the air that we breathe in. That's why if there is a problem in your patient's capacity to breathe air, then um, there could be an impairment, okay, and the healing process, okay, would be hard if your bronchi, okay, does not function well. All right. So the large air passages that lead from the trachea to the lung. So amo itong bronchi, ha? It is where the air will pass through from, okay, galing sa trachea to the lungs. So amo itong bronchi, right? So ito ya, bronchi. Mhm. Okay. So there are a lot of bronchi class. Okay? So dyan dumadaan ang hangin. Alright? So bronchi represent the large air passageway leading from the trachea into the lungs. Okay. So the right mainstem bronchus. Okay. Ito ha. Ito siya. The right mainstem bronchus originates higher than the left mainstem bronchus. Ito yung left. It is also shorter, wider, and more vertical. It measures about 2.5 centimeter and appears as a direct continuation of the trachea. Okay, so ito ang right, ito ang left bronchus. So mas maliit ang right primary bronchus, wider and more vertical. Okay? Alright, so the left mainstem bronchus is about 5 centimeter in length. Okay, so always remember right primary bronchus 2.5 centimeter. So shorter. Left mainstem bronchus is 5 centimeter in length. So mas mahaba. Okay? So that those are your bronchi. Okay? Singular form is bronchus. So, yan. Okay? Left and right. Okay? Remember, bronchi is the passageway of large air from your trachea to your lungs. Okay? So, what are bronchioles? Okay, ito yun naman yung bronchioles, yung parang mga branches. Okay, so dito dadaan yung hangin, class. The oxygenated blood. Okay, so yan, branches, those are bronchioles that brings the air to your alveoli. Okay, and inside your alveoli, there is the alveolar ducts and the alveolar sacs. Alright? So, functions of the bronchioles. Para saan yung bronchioles? Okay, you can see the bronchiole, right? Okay, that one. That's the bronchiole. Okay. The bronchioles carry oxygen-rich air into the lungs and carry carbon dioxide-rich air out of the lungs, thereby aiding in the process of breathing and respiration. So, when we breathe in, okay, when we breathe, okay, the bronchioles is the one that carries the oxygen inside our lungs. Okay? And it will also bring the carbon dioxide outside of our lungs. Kaya nga, the main function of respiratory system is breathing. Okay? So we can see the pulmonary artery and we can see the pulmonary vein. Okay. So when we say class, pulmonary vein, that's the red one. This one, that is the pulmonary vein, red in color. Okay. So pulmonary vein carries the oxygenated blood. Okay. Red nga ni, pulmonary vein nga ni, hiya ang nagdadalahan oxygenated blood. Meaning to say the blood with oxygen. Blue nga ni, that is the artery, that is the one carrying the deoxygenated blood, meaning wala ng oxygen. Okay? Alright. So the smooth muscle that surround the bronchioles can constrict or dilate the airway, which can aid in getting the proper amount of oxygen into the blood. So, for example, okay, these are the smooth muscles. Yung parang XX, okay, those are the smooth muscles that surround the bronchioles. So this is your bronchiole, it's like a tree, okay, and this bronchiole, okay, may be constricting or dilating. Okay? Your smooth muscle can constrict it, make it narrow, and then dilate, okay? Make it wider, okay? Which can aid in getting the proper amount of oxygen into your blood. Okay, so you can see here the oxygenated blood from pulmonary artery, okay, blue one. Oxygenated blood to pulmonary vein, red one. All right. So you can see the parts. Okay. All right. So smooth muscle contraction leads to bronchoconstriction or the decrease in the diameter of the bronchioles, while smooth muscle relaxation leads to the bronchodilation increase in the diameter of the bronchioles. Okay, so you already know what bronchoconstriction means, but you don't know, okay, how it how it happens inside the body. Okay, so when it constricts, okay, when there is bronchoconstriction, there is a decrease in the diameter of the bronchioles, okay, thus decreasing the passageway of the air. All right, so you have to remember the parasympathetic stimulation. Okay, parasympathetic stimulation causes bronchoconstriction, while sympathetic stimulation causes bronchodilation. Okay, so what do we mean by parasympathetic stimulation? Okay, so parasympathetic stimulation causes bronchoconstriction. So the lungs, no, breathing will slow down if your bronchi has constricted. Okay? The bronchi, the tubes that bring air to the lungs, will get narrower. So you can see the picture. Huh? If there is an inflamed lung airway, okay, so this is the narrowed airway and puno na siya ng mucus. Okay? So, nag-narrow siya. When we say nag-narrow, nag-bronchoconstriction. So, this is what happens when there is bronchoconstriction inside of your bronchioles. Okay? While this is the normal lung airway. So, kung hindi siya nag-constrict, class, no, malaki ang daanan ng air or ng oxygenated blood. Okay? Alright, so bronchospasm. Okay, we always hear about bronchospasm, but what is bronchospasm? Bronchospasm is a tightening of the muscles that line the airways or bronchi in your lungs. Okay, so this is the normal airway. Okay, this is the wall that is inflamed and thickened. Okay, so ito siya. Okay, when we say relax smooth muscles, nag-vasodilate. And when we say the tightened smooth muscles, nag-vasoconstrict or nag-bronchoconstriction. Okay. So, study the three. Alright? So, what are the alveolar ducts? Okay. So, you already know the bronchioles. And then this is the alveoli. And this is the alveolar duct. Okay? And the alveolar sacs. Okay. With the cluster of alveoli, okay, and then this is the terminal bronchiole. Okay, so what is the function of the alveolar ducts? Okay, so imagine, okay, this is your bronchioles, this is the alveoli, this is the alveolar duct, and this is the alveolar sac. Okay, so the part of the respiratory passages beyond the respiratory bronchioles from which the alveolar sacs and the alveoli arise. The smallest of the intralobular ducts in the mammary gland into which the secretory alveoli open. Okay? So, alveolar ducts assist alveoli in their function. Alveoli handles, okay? This is your alveoli, okay? This is your entire alveoli, and that handles the gas exchange. Alveolar ducts, okay? This one, all right. Alveolar ducts, okay? This is your alveolar ducts. They collect the air that has been inhaled and transported it to the tract, and disperse it to the alveoli in the alveolar sac that they feed into. Okay, so ito yung alveolar sac. Alright. So gikan im alveolar duct, okay, they are the ones collecting the air that we inhale. So when we inhale, it is collected by the alveolar duct, and it will be transported to your alveoli, and then the alveolar sac, okay, is where they feed into. So doon yung oxygenated air doon ipapasok lahat sa alveolar sac. Okay? All right. So that is an alveolar sac. Okay? The entire it's like grapes, no? But that's the alveolar sac where your oxygenated blood will go into. Then that is the alveoli, and that's the bronchiole. Okay, so you can see that a pulmonary vein or venule carry the oxygenated blood. Red means oxygen, okay, and then blue means the carbon dioxide or the deoxygenated blood. So papasok, you papasok yung oxygen that, um, and then palabas yung deoxygenated blood. Okay? So, at least man lang yan, klaro in your mind. Alright? And then we have the pores of Kohn, and then alveolar duct, and then alveoli. Alright. And then the pulmonary capillaries surrounding the alveoli. Okay? So the alveoli are where the lungs and the blood exchange oxygen and carbon dioxide during the process of breathing in and breathing out. Oxygen breathed in from the air passes through the alveoli and into the blood and travels to the tissues throughout the body. Okay? So you can see the pulmonary artery carries the deoxygenated blood outside. Okay? So from the lungs outside, and then the pulmonary vein carries the oxygenated blood. Okay, and this there's your bronchiole, and then the alveolar sac is in circle. Okay, kikita mo yan. That's the alveolar sac. Okay, and this is the alveoli. Ito. So inside the alveoli are the alveolar sacs. Okay, so how does oxygen get into the bloodstream? A protein called hemoglobin in the red blood cells then carries the oxygen around your bodies. Kaya, it is very important that you understand your subjects from pharmacology to nutrition para maganda yung pagka-interpret mo ng nursing care management. Okay, so why do we eat protein? Because protein, okay, has hemoglobin in itself is made of protein. Okay? And hemoglobin is a part of the blood, is a part of the red blood cells that carries the oxygen around your body. Okay? Hindi lang sa lungs, but in your entire body. So you have to eat protein because hemoglobin carries the oxygenated blood. Okay, so oxygenated blood is this one, the red one. Okay, so your blood class travels in the same way as your emboli or your emboli will travel. Okay, so normally kung the process is normal, so your blood is always, for as long as we are alive, for as long as we are breathing, okay, our body will continue to work, and the oxygen will be distributed in the entire body system. Or else, kung walang oxygen, we will go in coma, okay, and some other um, complications, okay. So at the same time, carbon dioxide that is dissolved in the blood comes out of the capillaries back into the air sacs, ready to be breathed out. Okay, so the carbon dioxide is dissolved in our blood and we breathe it out. Okay, so amo itong carbon dioxide pagawas. Okay, all right. Then the blood vessel. Okay? So blood with fresh oxygen is carried from your lungs to the left side of your heart, which pumps blood around your body through the arteries. And blood without oxygen or the deoxygenated blood returns through the veins to the right side of your heart. From there, it is pumped to your lungs so that you can breathe out the carbon dioxide and breathe in more oxygen. Okay? All right. Okay, so the right lung is divided into three lobes, upper, middle, and lower. The left lung into two lobes, upper and lower, and the structures of the chest wall. So we have ribs, pleura, muscles of respiration. They are also essential. Kasi kung walang ribs, okay, what will protect your lungs from injuries? Okay, pang walang pleura, if there is no pleural space, then magiging it would be so easy for your if there is no um let's just say a liquid or a pleural space between the lining of your lungs to the inner portion of the lungs to the outside portion of the lungs, then madali siyang um, ma-scratch or madali siyang ma-damage. Alright? So that's why we need some lining, okay, the pleural lining to protect the lungs from any injury. And then muscles of respiration. Okay? So we have the upper lobe, the middle lobe, the lower lobe. Okay. So we have the nasal cavity, alright? So there are so many things. Okay, our bodies is very complex. No, it was and it is wonderfully made by God. So we have the cilia. Okay, it's like it's the cilia. Okay, it's like the what we call this one in our skin. All right, and then the dust particle, and then the mucus, and then the goblet cell. Okay, and then respiratory bronchiole. All right. So you have this one is the carina. Okay, in between. Okay, so those things. Okay, so physiology of respiration, ventilation involved inspiration. Okay, the movement of air inside the lungs, and expiration, the movement of air outside of the lungs. So air moves in and out of the lungs because intrathoracic pressure changes in relation to pressure at the airway opening. So contraction of the diaphragm and intercostal and scalene muscles increases chest dimensions, thereby decreasing intrathoracic pressure. So gas flows from an area of higher pressure, the atmospheric pressure, to one that is lower, or the intrathoracic. Okay. So equipment needed: stethoscope, peak flow meter. So that one, upper lobe, middle lobe, lower lobe. Okay, so that's how it looks like. That's how it is divided. So this is the lower lobe. So dyan banda, ha, ang lower lobe, more or less in your fifth or sixth intercostal space. Okay, then upper lobe, and then this is the middle lobe. That's why we really have to be careful with our chest. Okay, because after our chest is the lungs. All right, and then this one is the opaque or the oblique way, right? And then mid clavicular line. Okay, so mid clavicular line, right? That's why when you are being asked what is a midclavicular line, you would understand that is the vertical way or vertical portion. Okay, so this is the midclavicular line. Okay, and then right anterior axillary line near your axilla, and then mid-sternal line. Okay, in the middle. Okay, so the mid-clavicular is near your clavicle. Okay, and then this is the lobes. Okay, so first rib, this is your first rib. This is your angle of Louis. Okay, and then left upper lobe and then left lower lobe. Okay, so these things you have to always remember. Okay, so that is the anatomy, okay, landmarks and structures of the chest wall. Okay, so position and lighting and draping. Okay, so we will not talk much on those things. You already know what are those. Okay, so the basic steps of the examination. Okay, so inspection, palpation, percussion. We're just having a review before we go to the diseases. Okay, and then health history. Okay, so ask for any risk factors for respiratory disease such as smoking, exposure to smoke, history of attempts to quit, methods, results in active lifestyle, immobilization, age, environmental exposure such as dust, chemicals, air pollution, obesity, and family history. Okay, and then cough. Okay, so there is, what are those types of cough? There are so many types of cough. There is dry cough, moist cough, wet cough, and then productive cough. Okay, ubo ng ubo, and then maraming phlegm. Okay, that is a productive cough. And then when was the onset? Okay, because if the cough has been 10 days already, that is already considered tuberculosis. Okay, more than 10 days na cough. Okay, um, it's no longer the simple cough. Okay, it could be TB and some other respiratory diseases. Okay, so duration, ilang araw, pattern, activities, time of the day, okay, weather, because pneumonia and some other respiratory related illnesses. Okay, there are phlegm or there are signs and symptoms that we are looking for to, in order for us to differentiate what kind of diseases are these. Okay, so severity, wheezing, associated symptoms, treatment, and effectiveness. All right, so sputum. All right, so what is the amount? Gaano karami? What is the color? Is it green? Okay, is it yellow? Is it orange? Okay, is it clear or whitish? Okay, so what color is the sputum? Presence of blood or hemoptysis. Odor, mabaho ba? Because if it is bacterial, okay, may amoy talaga kasi it's comparable to a pus or nana, di ba? So consistency, pattern of production, in the past health history, respiratory infections or diseases, trauma, okay, surgery, chronic conditions of other system, family health history, tuberculosis, emphysema, lung cancer, allergies, and asthma. Okay, so inspection. Okay, so class, wag maging lazy. Okay, we will go to the ward. Okay, learn as much as you can in the RELE because that is the application of your knowledge. And it is so sad to graduate and you did not even see, okay, what is a scoliosis, what is a barrel chest in real life, what is a kyphosis, okay. So tracheal deviation can suggest of tension pneumothorax, okay. So there would be chest wall deformities. Okay, kyphosis, curvature of the spine, anterior posterior, scoliosis, curvature of the spine, lateral, and barrel chest wall increased anterior posterior, normal in children, typical of hyperinflation seen in COPD. Okay, so barrel chest. You can see that in Google, or you can see that in Cogier or in your Brunner and Sudar. So you really have to read what is a barrel chest, and if there is a chance for us to see a barrel chest in the ward in person, that would be better because whether we like it or not, our job is to assess, okay, inspect, palpate, percuss, okay. Wag magtamad-tamaran because we are nurses, and the expectations from us is high. Okay, when it comes to nursing care, okay, we have to relate also to the medicine people. All right, so thoracoplasty with secondary changes in the spine, and then pectus excavatum, okay, parang ano, ang liit-liit. It has like, it has a depression. When we say depression, um 1 or 2 inches below or sunken, okay, and then kyphosis. Okay, so kyphosis, you can see that, oh, this kyphosis. All right. So if may kyphosis ang isang tao, okay, um the respiration and breathing pattern is also diminished or affected or impaired. Okay? Kasi, meaning yan sa ilalim. No? It's either the lungs are extended or the lungs are elongated. Okay? Because there is also a malformation of the body system. Okay? Or of the rib cage. Alright? So, um, iba din yung magiging ano ng lungs mo. Okay, so signs of respiratory distress, cyanosis, persons turn blue, uh, pursed lip breathing, seen in COPD, used to increase end expiratory pressure, accessory muscle use, scalene muscles, diaphragmatic diaphragmatic paradox, the diaphragm moves opposite of the normal direction on inspiration, suspect flail segment in trauma, and intercostal in drawing. Okay? So, class, okay, you can see, say, you have to be very good with assessment. Kasi sayang man yung learning. Okay, so that is a blue bloater, okay, showing ascites from mark core pulmonale. Okay, so pag may ascites, lalaki yung tiyan. Okay, because there is a displacement in the fluid in the stomach. Okay, so yan yung ascites, so blue bloater, and then pink puffer. Note the pursed lip breathing. Okay, yung ganon. Alright, okay. So palpation, okay? Tactile fremitus is vibration felt by palpation. So place your open palms against the upper portion of the anterior chest, making sure that the fingers do not touch the chest. Okay, so you will say 99, 99, 99. Okay, so you can feel, when you feel that kind of vibration, that is the resonance in the lungs. Okay, so you should feel vibration of equally intensity on both sides of the chest. Examine the posterior thorax in a similar manner. The fremitus should be felt more strongly in the upper chest with little or no fremitus being felt in the lower chest. Okay? So, ganyan. Okay? And then, assessing chest expansion and expiration. Left end inspiration, right? Okay, when you have your breathing exercises. Okay? Percussion over the anterior chest, and then direct percussion of the clavicles for disease in the lung apices. Okay. So, auscultation. To assess breath sounds, ask the patient to breathe in and out slowly and deeply through the mouth. Begin at the apex of each lung and zigzag downward between intercostal spaces. Listen to the diaphragm portion of the stethoscope, because it's very sad if you do not know how to auscultate. It's very sad if you do not know what to listen. Kaya, while you have the chance, do auscultation with your patients. Okay? Establish rapport, and then examine. You have to hear it, because when you hear it, you can distinguish what is a stridor, what is a ral, what is what are those breath sounds. Okay, all right. So you have to take note of the normal breath sounds, the pitch, the note, the intensity, the quality, and the duration. Okay, these are the things that you should have been writing in your FDAR or in your nurse's notes. Diba? Ang dami-daming dapat gawin. Okay? So normal breath sounds, we have the bronchial, bronchovesicular, vesicular, and diminished. Okay. So we'll tackle that in RLE. Okay. So tactile firmitus. Okay, that's how you should position your hands, and then you'd say 99. Okay, the patient would say 99, 99, 99. All right. Okay. Right? So there is resonance, hyperresonance, timpani, yung drum-like, loud, empty quality heard over gas-filled stomach. So dapat you should know what a timpani is, and then dull, and then flat. Okay. So resonant over lung tissue, and then flat over heavy muscles and bones, cardiac dullness, stomach timpani, okay, and then the liver. Okay. All right. So visceral flatness. Okay, so bronchial over trachea, and then bronchiovesicular over main bronchi. Okay, so pag bronchial, okay, walang bronchial na below the um below the bronchi. So yung bronchial sound, nandyan lang yan sa trachea. Okay. Bronchovesicular over main bronchi, that these two, and then vesicular breath sound over lesser bronchi, bronchioles, and lobes. Okay. So when you auscultate, you should know that the bronchial is here. Okay. And then the bronchovesicular over here, and then at the bottom part is the vesicular. Okay. Right. So this is the posterior chest and the anterior chest. Okay. So now we will begin with the diseases. Okay. And I hope that you are taking down notes, people. Okay. You have to learn these things. Okay. Because um, these are essential when we go on duty. When the duty will um, resume, no? When everything is fine and we will go to the hospital, you have to carry all your knowledge with you. Okay? So let's begin with the pleural effusion. Okay, so pleural effusion is a collection of fluid in the pleural space, is rarely a primary disease process but is usually secondary to other diseases. So the pleural space normally contains only about 10 to 20 ml of serous, hindi serious, it's serous fluid, like a yellowish fluid. Okay, so 10 to 20 ml. Alright, so pleural fluid normally sips continually into the pleural space from the capillaries lining the parietal pleura and is reabsorbed by the visceral pleural capillaries and lymphatic system. Any condition that interferes with either secretion or drainage of this fluid leads to pleural effusion. Okay, so pleural effusion. When we say pleural effusion, there is a collection of abnormal amount of fluid in the pleural space. So, ang normal class ha, 10 to 20 ml ang ada in pleural space that's surrounding the lungs. Now, if there is pleural effusion, sumobra, naging 50 ml. Okay? So, classification, we have the transudative effusions and we have the exudative effusions. Okay, so transudative effusions, also known as hydrothoraces, occurs primarily in non-inflammatory conditions in an accumulation of low protein, low cell count fluid. So cause of transudative effusion, increased hydrostatic pressure found in heart failure, most common cause of pleural effusion. Decreased oncotic pressure from hypoalbuminemia found in cirrhosis of liver or renal disease. Okay, in this condition, fluid movement is facilitated out of the capillaries and into the pleural space. Okay, So exudative effusions occur in an area of inflammation in an accumulation of high protein fluid. Okay, so an exudative effusion results from increased capillary permeability characteristic of inflammatory reaction. Okay, so this type of effusion occurs secondary to conditions such as pulmonary malignancies, pulmonary infections, and pulmonary embolization. Okay, so etiology: disseminated cancer, particularly lung and breast lymphoma, and then pleuropulmonary infections or pneumonia, heart failure, cirrhosis, nephrotic syndrome, and other conditions like sarcoidosis, systemic lupus erythematosus or the SLE, and peritoneal dialysis. Okay? Dahil permeable ang capillaries. Okay? So it is easy for the fluid to pass through. Okay? So pathophysiology, okay, increased hydrostatic pressure, decreased oncotic pressure, unable to remain the fluid within an intravascular space. Because supposed to be, if normal lahat, if normal ang lining ng lungs, if the pleural space has enough fluid from 10 to 20 ml, dapat hindi lumabas, okay, yung fluid from the intravascular space. Okay, so when the fluid shift, okay, in, into the interstitial space na dapat wala doon ang fluid, that's when effusion occurs. Kaya tinawag siyang pleural effusion. There is an accumulation of more than enough fluid. Okay? So invasion of microbes, initiation of inflammatory reaction, vasodilation or increased capillary permeability, leak, okay, magli-leak na ang plasma protein, decrease oncotic pressure, and then fluid shift into the interstitial space. Okay, so what are the clinical manifestations? Usually, the clinical manifestations are those caused by the underlying disease and severity of effusion. Pneumonia causes fever, chills, and pleuritic chest pain. Malignant effusion may result in dyspnea and coughing. Okay? So, pag may pneumonia, okay, mataas ang fever, nag-chills. Okay? So, when I was working in the BPO industry, I had workmates na pabalik-balik ang ubo. On and off ang lagnat. Pagkadto ha, doctor, pneumonia na pala. Okay, so, pneumonia class is infectious or contagious. Okay, so, kung napulo ka mo and then aircon siya, maarin ang magka-pneumonia lahat. Okay? That's why you have to take good care of your respiratory system. You have to drink a lot of water. Okay? You have to drink vitamins. Drink vitamin C's. Eat vegetables. Eat fruits. Okay? Iwas sakit because you have to protect your immune system. Okay? So, when a small to moderate pleural effusion is present, dyspnea may be absent or only minimal. Pleuritic chest pain, dullness or flatness to percussion, and decreased or absent breath sounds. Okay? So, diagnostic evaluation, chest x-ray or ultrasound detects presence of fluid. Thoracentesis, biochemical, bacteriologic, and cytologic studies of pleural fluid indicates cause. Okay? So, ganito ang may pleural effusion. Okay? Ganito ang x-ray. So, you can see na ito siya, fluid yan. Yung parang puti. Okay? So, supposed to be wala siya dyan. Kaso, because there is already capillary permeability, pumapasok yung fluid inside of the lungs. Okay? So, management. Alright, the objectives of treatment are to discover the underlying cause, to prevent reaccumulation of fluid, and to relieve discomfort, dyspnea, and respiratory compromise. So general treatment is aimed at underlying cause, heart disease and infection, and thoracentesis is done to remove fluid, collect a specimen, and relieve dyspnea. So yung maraming, if there is a pleural effusion and there is so much fluid in the lungs, to a point na magdi-difficulty of breathing ng imo pasyente, That's why thoracentesis is done. Okay? Just to remove the fluid. Amo ito na ilang ginsisiri nga ginkuha ang tubig habaga. Okay? Through thoracentesis. So, for malignant effusions, just tube drainage, radiation, chemotherapy, surgical pleurectomy, pleuroperitoneal shunt, and pleurodesis. So, these are already cases, no, with those patients that are having lung cancer, for example. Right? And then complications. Large effusion could lead to respiratory system. Okay, so nursing assessment. Okay, this is our job. We always have to assess. Obtain history of previous pulmonary condition. Assess patient for dyspnea and tachypnea. Auscultate and percuss lungs for abnormality. So, mamay ka, di ba? The difficulty of breathing na yan, it's very fast or tachypnea, wala ka lang. Okay, it should signal that there is something wrong with our patient. Okay? So, um, nursing diagnosis and effective breathing pattern related to collection of fluid in pleural space, secondary to lung cancer as evidenced by labored breathing with a respiratory rate of 8 out of 14 cycles per minute. Okay? So, nursing interventions, maintaining normal breathing pattern. So, institute treatments to resolve the underlying cause, all right, as ordered, and assist with thoracentesis if indicated. So maintain chest drainage as needed and then provide care after pleurodesis. So monitor for excessive pain for the sclerosing agent which may cause hypoventilation. Administer prescribed analgesic. Assist patient undergoing installation of intrapleural lidocaine if pain relief is not forthcoming. So lidocaine is one of those simpler anesthesia. Administer oxygen as indicated by dyspnea and hypoxemia. Observe patient's breathing pattern and then observe also the oxygen saturation. So that's why you have to be keen on your observation class because the reason why we have diagnostic exams and for you to relate it with the patient's um, case so that you would know what will be your nursing interventions and so that we can save the life of the patient. Okay? So, expected outcomes, report absence of shortness of breath. So, pag nagtitika, upay na ang kalagayan ng pasyente, so, wala ng shortness of breath. Okay? Nag-normalize, kung baga. Meaning to say that our nursing interventions were effective, okay, or were helpful. Alright, so what is emphysema? Okay, so emphysema, alveoli with emphysema, puno siya, that's the alveoli with emphysema. Okay, so wala na yung mga lines, right? And then microscopic view of normal alveoli is supposed to be ganito ang normal alveoli. Okay, so definition, emphysema is the enlargement and destruction of the alveolar, bronchial, and bronchular tissue with resultant loss of recoil, air trapping, thoracic overdistension, sputum, accumulation, and loss of the diaphragmatic muscle tone. These changes cause a state of carbon dioxide retention, hypoxia, and respiratory acidosis. So kung may emphysema, hindi lumalabas ang carbon dioxide. Okay? Nare-retain siya aton lungs, amo ito nga, di ba, nasusuffocate. Kaya puro carbon dioxide ang aada. And then, when we are being suffocated dahil wala ng oxygen sa brain, so hypoxia occurs and there would be respiratory acidosis. Okay? So, matatrap ang air. So, mag-over-distend ang hemothoracic and then sputum accumulation. Dadami ang sputum, haimlaws. Okay? And then loss of the diaphragmatic muscle tone. Okay? That's emphysema. Okay? So, the actual cause of emphysema is unknown. Risk factors for the development of emphysema include cigarette smoking, living or working in a highly polluted area, and a family history of pulmonary disease. Frequent childhood pulmonary infections have been identified as a cause of bronchiectasis or ectasis. Okay? So, ganun na lang. Sigarilyo pa more. Okay? The more you smoke, okay, that is a condition where your lungs is prone to emphysema. And hindi madali. Pag when your lungs collapses, okay, goodbye, world. Alright? So, assessment. We always have to assess. Okay? So, feeling of breathlessness. Okay. What to assess in emphysema? Cough, sputum production, flaring of the nostrils, use of accessory muscle of respiration, increased rate and depth of breathing, dyspnea, decreased respiratory excursion, resonance to hyperresonance, decreased breath sounds with prolonged expiration, normal or decreased fremitus, okay, and then frequent childhood pulmonary infection. Okay. So, primary nursing diagnosis, impaired gas exchange related to destruction of alveolar walls secondary to lung cancer, and then just put the evidences. Okay? So, diagnostic evaluation. Evaluation entails primarily chest x-rays, chest computed tomography or CT scans, pulmonary function test, pulse oximetry, blood gases, and complete blood count. Okay. Medical management. Okay. The major goals of medical management are to improve quality of life, slow progression of the disease, and treat obstructed airways to relieve hypoxia. So treatment is directed at improving ventilation, decreasing work of breathing, and preventing infections. So smoking cessation, physical therapy to conserve and increase pulmonary ventilation, maintenance of proper environmental conditions to facilitate breathing, psychological support, ongoing program of patient education and rehabilitation, bronchodilators and metered-dose inhalers like aerosol therapy, dispensing particles in fine mist, and then treatment of infection or the antimicrobial therapy at the first sign of respiratory infection, and then oxygenation in low concentrations for severe hypoxemia. So you can see that the medical management is very technical. Okay? It is very disease oriented. So kung ano ang sakit, all right? So their goal is the slow progression of the disease. If it is cancer, so slow progression. So amo an ira an ira management is chemotherapy, radiation, and then how to relieve hypoxia, and then oxygen. Okay? So improving ventilation. So that is the medical management. However, okay, as nurses, we also have nursing interventions. And our concern is the patient. Okay? So there's also pharmacologic interventions, so the bronchodilator, anticholinergic agent. So you have already met that in your pharmacology. So, paki-review na lang. Anyway, I'll be giving you the handout. So that's why it's very important that you would know the action of the drug, the indication of the drug, the side effects of the drug, the side effects or the adverse effects of the drug. Okay, so which will come first, the bronchodilators or the steroids. Okay, so you should know those things. What are the antidote? Okay, in cases of emergency. So if there are infection, naturally antibiotics will be given. Okay, and as a preventive measure before pa magkakasakit, we have influenza and pneumonia vaccines. Okay? So nursing intervention. So this is our job. Okay? Maintaining a patent airway is a priority. Use a humidifier at night to help the patient mobilize secretions in the morning. Encourage the patient to use controlled coughing to clear secretions that might have collected in the lungs during sleep, instruct the patient to sit at the bedside or in a comfortable chair, hug a pillow, bend the head downward a little, take several deep breaths, and cough strongly. Place patients who are experiencing dyspnea in a high power position to improve lung expansion. Placing pillows on the overhead tables and having the patient lean over in the orthopnic position, okay, may also be useful. And then teach the patient pursed-lip and diaphragmatic breathing, and to avoid infection, screen visitors for contagious diseases, and instruct the patient to avoid crowds. So you see, we have so much to advise. We have so many things to do. Okay, so do not tell me na walay ka matcha-charting, kay damo kita dapat na i-advise sa pasyente. Because these nursing interventions are very helpful. Okay, just by mere talking to your patient or telling your patient, you know, biski ka pa waray health teaching na bongga. Okay? Pag health teaching na from your mouth, okay, from your knowledge, dako na ito nga bulig haira. Okay? Just to control the coughing, okay, to clear the sick. Pag siringla, coughing exercise kita para mga sputum haimlang sa imo mapagawas or maubo para guti na la didto. Okay? Kasi when we are sleeping, okay, we are immobile. So, nagpupunduan sputum. Okay? Alright, so conserve the patient's energy in every possible way. Plan activities to allow for rest periods kay may emphysema nga, di ba? Eliminating non-essential procedures until the patient is stronger. It may be necessary to assist with the activities of daily living and to anticipate the patient's needs by having supplies within easy reach. Okay. So marami kang ikaka-advise. Rest period, sleeping pattern, um, diet, okay? Refer the patient to a pulmonary rehabilitation program if one is available in the community. Patient education is vital, okay? Patient education is vital to long-term management. Teach the patient about the disease and its implications for lifestyle changes, such as avoidance of cigarette smoke and other irritants, activity alterations, and any necessary occupational changes. Provide information to the patient and family about medications and equipment, and then document. Okay? So documentation guidelines. Rate quality and depth of respirations, vital signs, physical findings, dyspnea, cyanosis, decreased muscle mass, cough, increased anteroposterior chest diameters, and use of accessory muscles. So, pag naggagano na, obvious ba? Use of accessory muscles during respiration, and then characteristics of sputum, and then activity tolerance or activity intolerance, and then ability to perform self-care. Signs and symptoms of infection, response to pharmacologic therapy, response to oxygen therapy. Okay? So discharge and home healthcare guidelines. Be sure that the patient and family understand any medication prescribed, including dosage, route, action, and side effects, because this is a very challenging part class, especially if your patient's significant others are very meticulous. They will always ask, what is the action of the drug? Para saan ang ini-inject mo sa pasyente ko? Ano ang dosage, ano ang route, ano ang action, ano ang side effects. Because also, if di ka mag-explain, okay, and then something untoward incident will happen or untoward reactions will happen, might as well, di ba, you have to remind the patient so the patient can report to us immediately if something is going on. Okay? And then instruct the patient to report any signs and symptoms of infection to the primary healthcare provider. Explain necessary dietary adjustments to the patient and family. Recommend eating small, Frequent meals, including high protein and high density foods. Encourage the patient to plan rest periods around his or her activities, conserving as much energy as possible. Kasi nahihirapan na huminga, mag-active pa ang pasyente mo, di ba? So, rest periods. Okay? Arrange for return demonstrations of equipment used by the patient and family. If the patient requires home oxygen therapy, refer the patient to the appropriate rental service and explain the hazards of combustion and increasing the flow rate without consultation from the primary healthcare provider. So you always have to teach the client. Okay, patient teaching or health teaching is very important, especially the discharge instructions. That is still under your responsibility and accountability as a nurse. And please, if you are a student nurse in the medical ward and you have seen somebody smoking, tell them to go away, okay? Especially if they are near the oxygen tank, or else pupotok ang buong ward. Okay? Small things matter, class. Okay, and the next, pulmonary edema. So pulmonary edema is the accumulation of fluid in the air sacs or alveoli in the lungs. Okay, so description. Pulmonary edema is an abnormal accumulation of extravascular fluid as the lung parenchyma that interferes with adequate gas exchange. This is a life-threatening situation that needs immediate treatment. The most common cause of cardiogenic pulmonary edema is the left ventricular failure exhibited by increased left atrial ventricular pressures. Risk factors include ischemic heart disease, cardiomyopathy, valvular disease, myocardial infarction, and acute septal defects. Okay, so you should know what is ischemia. Okay, so signs and symptoms: shortness of breath, orthopnea, okay, moist cough with pink frothy sputum. Okay, so when we say orthopnea, okay, from biglang tatayo agad, okay, or biglang uupo agad. Alright? So, nahihirapan sa paghinga because the air, okay, cannot easily travel, alright, and there would be changes in the body. Okay, so pag bigla kang tatayo, alright, and then moist cough with pink frothy sputum, chest discomfort, palpitations, fatigue, syncope, cyanosis, and respiratory distress. Okay, so appearance, anxious, diaphoretic, clammy skin. Vital signs, sustained tachycardia, and then BP less than 90 mmHg, RR or respiratory rate greater than 30, and then, alright, and then greater than 30 breaths per minute, and falling of the auto saturation. Okay, so that is the cardiovascular. So we would have tachydysrhythmias with possible ectopy, and then murmur, mitral regurgitation, S3 with possible S4, and then pulmonary, there would be respiratory distress, respiratory failure, orthopnea, coarse bilateral crackles, wheezing, rhonchi, cough with frothy sputum. Okay, so acute care management. All right. So with the acute care management, nursing diagnosis, okay, impaired gas exchange related to increased pulmonary congestion, secondary to increased left ventricular and diastolic pressure, as evidenced by bluish discoloration of the skin. Okay. All right. So outcome criteria. So respiratory rate 12 to 20 breaths per minute, apnea, lungs clear to auscultate, and then the those vital signs or those diagnostic normal values should be present. Okay, so nursing interventions. All right, let's focus class on the nursing intervention. So patient monitoring, continuously monitor oxygenation status with pulse oximetry monitoring, Monitor ECG for dysrhythmia development that may be related to hypoxemia, acid-base imbalance, or ventricular irritability. Calculate arterial alveolar oxygen tension ratio as an index of gas exchange efficiency, and document hourly the input and output to monitor fluid status. Obtain daily weights. So, ayaw it kalimti ang mga input and output. Those are very important things. Okay, when we go on duty. All right. So patient assessment. Measure HR, heart rate, respiratory rate, blood pressure every 15 minutes to evaluate the patient's response to therapy and to detect cardiopulmonary deterioration. Kasi class, ang bilis-bilis lang yan eh, no? If there is deterioration, like, aalis ka lang sa ward ng 15 minutes. Okay? Pagbalik mo, wala na, nag-deteriorate na. That's why you have to check the vital signs every 15 minutes. Okay? Then assess the patient for changes that may indicate respiratory compromise, necessitating intubation and mechanical ventilation. Okay? Alright, so diagnostic assessment. Okay? Review ABGs for hypoxemia and acidosis, which may further compromise tissue perfusion and to indicate need for mechanical ventilation. So review serial chest radiographs for worsening or resolving pulmonary congestion. Review lactate levels as an indicator of anaerobic metabolism. Okay? So when we say anaerobic, okay, it has to do with the oxygen. Alright, so patient management, provide supplemental oxygen via mask or nasal cannula as indicated. Administer diuretic agents or niseritide to reduce circulating volume, which will improve gas exchange. Monitor urine output and electrolytes. Administer vasodilating agents to redistribute fluid volumes, which will facilitate gas exchange. And then morphine sulfate may be ordered to promote preload and afterload reduction to decrease anxiety. Okay? So next is the ARDS, or the acute respiratory distress okay, syndrome. Okay, so description. It is a form of acute respiratory failure that occurs as a complication of some other condition. Is caused by a diffuse lung injury and leads to extravascular lung fluid. So the major site of injury is the alveolar capillary membrane. The interstitial edema causes compression and obliteration of the terminal airways and leads to reduced lung volume and compliance. Okay, so maaram ka naman kung ano ang edema, di ba? So nag-edema ha interstitial space. So nagko-compress itong lahat nagko-compress ang imo lungs, na-compress, kay damo na fluid. Okay, so of course, pag na-compress, mas maraming fluid, the more na di rin nakakapass through an air, okay, so reduced lang volume. Okay, the ABGs identify respiratory acidosis and hypoxemia that does not respond to an increased percentage of oxygen. And the chest x-ray film shows interstitial edema. Some of the causes include sepsis. Okay. Sepsis, systemic infection. So pag nag-sepsis na ang pasyente mo, okay, toxic na ito. Fluid overload, shock, trauma, neurological injuries, burns, disseminated intravascular coagulation, drug ingestion and inhalation of toxic substances. Okay? So, ARDS can be caused by any major swelling, inflammation, or injury to the lung. Some common causes include breathing vomit into the lungs, aspiration, inhaling chemicals, pneumonia, septic shock, and trauma. Okay? So ARDS leads to a build-up of fluid in the air sacs. This fluid prevents enough oxygen from passing into the bloodstream. The fluid buildup also makes the lungs heavy and stiff and decreases the lungs' ability to expand. So, di rin na nakaka-expand ang lungs. Paano ka makaka-expand kung puno-punuan ka na hin fluid, di ba? Kaya nag-build up na dito ha sa cold. Okay, so the level of oxygen in the blood can stay dangerously low even if the person receives oxygen from a breathing machine or mechanical ventilator through a breathing tube called the endotracheal tube. Okay? So ARDS often occurs along with the failure of other organ systems. So multiple organ failure such as the liver or the kidneys, cigarette smoking and heavy alcohol use may be risk factors. Okay? So, diagnostic evaluation based on clinical criteria, history of risk factors, acute onset of respiratory distress bilateral, pulmonary infiltrates, absence of left heart failure, and severe refractory hypoxemia. So, chest x ray shows bilateral infiltrates and pulmonary edema. Okay, so primary nursing diagnosis, impaired gas exchange related to increased alveolar capillary permeability, interstitial edema, and decreased lung compliance secondary to acute respiratory distress syndrome as evidenced by labored breathing with a respiratory rate of 6 out of 14 cycle per minute. Okay, so other diagnoses that may occur in the NCP for ARDS, we have ineffective airway clearance, ineffective breathing pattern, activity intolerance, anxiety. You have to specify the level. Is it mild, moderate, severe, panic, or risk for aspiration? And in fact, um, in one of my researches, I had it here. There was there was a quote from Florence Nightingale saying, apprehension, uncertainty, waiting, expectation, fear of surprise do a patient more harm than any exertion. So, syempre, you are anxious, the impending doom. Yung feeling mo malapit ka lang mamatay kasi hindi ka na makahinga. That's why you have to specify if ano ba, mild anxiety ba ini, moderate anxiety, or severe anxiety. Okay, and then risk for aspiration. Okay, so medical management, identify and treat the underlying condition, ensure early detection, use aggressive supportive treatment, prevent infection, intubation, and mechanical ventilation, and then so on and so forth. Okay, so monitor arterial gas values. Okay, so you already had that in your diagnostic exams. So somehow we just have to review some of those, and we just have to focus also on the nursing interventions. Okay, so provide for the medical management, provide circulatory support, treat hypovolemia, carefully avoid overload, provide adequate fluid management, administer intravenous solutions, and provide nutritional support, so on and so forth. Okay, so pharmacologic intervention, okay, you may just read that on your own. So naturally, we will have the corticosteroids kasi um, there is ARDS. So ang aton mga medications liwat is for the relief, okay, in the lungs. Okay, and you also had in your pharma. Okay, so we will be using medications that are used only when the patient's gas exchange is so poor as to threaten his or her life. Okay, so neuromuscular blocking agents paralyze the patient without affecting mental status, so the patient requires sedation to counteract the accompanying fear and anxiety that occur when the patient is unable to move. Okay, the nitric oxide inhalation. All right, so nursing interventions identify and treat cause of the acute respiratory distress syndrome, administer oxygen as prescribed, position client in high Fowler's position, restrict fluid intake as prescribed, provide respiratory treatment as prescribed, administer diuretics, anticoagulants, or corticosteroids as prescribed, and prepare the client for intubation and mechanical ventilation using PEP. Okay, so nahihirapan na ngang huminga kasi merong acute respiratory distress syndrome, pinasupine position mo pa. So ano na, 'di ba? So position client in high Fowler's position and then restrict fluid intake. Puno-punuan na nga ang lungs ng nagkaano na nga, nagka-distress na nga ang lungs, painumin mo pa ng maraming tubig, so all the more magkaka-accumulation of fluid. So the more na hindi makakahinga. Okay? So, administer diuretics para maihi niya ang excess fluid in the body. Okay? And then anticoagulants and corticosteroids. Para ito, of course, anticoagulants is blood thinning. So at least di rin masyadong makapal ang blood in the passageway of blood. Okay? Or in the artery or vein. Okay? And then corticosteroids. Alright? Alright, so discharge and home healthcare guidelines. So, class, these things are very important because you're already a junior student. Next year, fourth year na kamo. So, when we will have the RLE, totohanan na na trabaho of a nurse. So, you have to know how to manage the discharge instructions. Okay, so prompt attention for any infections may decrease the incidence of sepsis, which can lead to ARDS and complications. If patients survive ARDS, few residual effects are seen, and complications are directed to any other conditions the patient may have. Okay, so documentation guidelines. Document the respiratory status of the patient, respiratory rate, breath sounds, and the use of accessory muscles, arterial blood gas levels, pulse oximeter, and chest x-ray results. Okay? Response to treatment, mechanical ventilation, immobility, and bed rest. So, presence of any complications depends on the precipitating condition leading to ARDS. Okay? So, acute bronchitis. So, these are inflamed primary and secondary bronchi. Okay? And then, acute bronchitis usually results from an infection such as a cold or flu. Okay? So, amo itong natatabo haim bronchi pag may acute bronchitis. So, from the root word bronchi, meaning to say bronchitis is inflammation of your bronchi. Okay, so amo ito. Okay, pag inflamed an bronchi, susugad, nagnanarrow, nagsiswelling, right? There would be pain, of course. So, pain is the fifth vital sign. Okay, so, sugad dito. Okay, so, minsan, no, danay, diri kita ay, ubo man la ini. Simple cough la ini. Or, ay, sipon la iton, diri nagpapa-doktor. Okay? Tapos, nagpapa-doktor, ano na, malubha na. So, ano nangyari? Acute bronchitis or bronchitis. So, pag nagka-bronchitis na, or malubhang-malubha na yung sakit, you know, even when things have become severe, and babasulo na ang nurse, ang doctor. Dapat sipon pa lang, no? Imo na i-treat, or else it will become bronchitis, otitis media, so on and so forth. Kasi connected lahat ang respiratory system. Alright? So description, it is an infection of the lower respiratory tract that generally follows an upper respiratory tract infection. So as a result of this viral, most common or bacterial infection, the airways become inflamed and irritated and mucus production increases. So causes, acute bronchitis is usually caused by viruses. Established risk factors include a history of smoking, occupational exposures, air pollution, reduced lung function, and heredity. So children of parents who smoke are at higher risk for pulmonary infections that may lead to bronchitis. Okay, so assessment. Fever, tachypnea, mild dyspnea, pleuritic chest pain, and then cough with clear to purulent sputum production, diffuse rhonchi, and crackles. Contrast with localized crackles usually heard with pneumonia. Okay, so diagnostic evaluation. Chest x-ray may rule out pneumonia. In bronchitis, films show no evidence of lung infiltrates or consolidation. And in the primary diagnosis, nursing diagnosis would be impaired gas exchange related to obstructed airways secondary to bronchitis as evidenced by increased mucus production. Okay. Medical management, chest physiotherapy to mobilize secretions if indicated, and hydration to liquefy secretions. Pharmacologic intervention, inhale bronchodilators to reduce bronchospasm and promote sputum expectoration. A course of oral antibiotics such as amacrolide may be instituted but is controversial. Symptom management for fever and cough. Okay, and then for the nursing intervention, encourage mobilization of secretion through ambulation, coughing, and deep breathing. Ensure adequate fluid intake to liquefy secretions and prevent dehydration caused by fever and tachypnea. Encourage rest, avoidance of bronchial irritant, and a good diet to facilitate recovery. Instruct the patient to complete the full course of prescribed antibiotics and explain the effect of meals on drug absorption. Okay? So, nursing interventions. Caution the patient on using the over-the-counter cough suppressants, antihistamines, and decongestants, which may cause drying and retention of secretion. So, kita atong practice may ubo, okay, dili magpapa-check up, ma-self-medicate. However, cough preparations containing the mucolytic guaifenesin may be appropriate. Okay? But danay imbis nga ma-relieve, no, worsen. So, advise the patient that a dry cough may persist after bronchitis because of irritation of airways. Suggest avoiding dry environments and using a humidifier at bedside, and then encourage smoking cessation. Teach the patient to recognize and immediately report any signs and symptoms of acute bronchitis. Okay, so documentation guidelines. Respiratory status of the patient, respiratory rate, breath sounds, use of oxygen, color of nail beds. Okay, color of nail beds. Kung pale ba ito, is it still pinkish? And the lips, note any respiratory distress, response to activity, degree of shortness of breath with any exertion, degree of fatigue, comfort, body temperature, baka may lagnat na, response to medications, oxygen and breathing treatments, need for assistance with activities of daily living, response to diet, and increased caloric intake, and then daily weights. Okay? So, discharge and home health care guidelines. So, medications. Be sure that the patient understands all medications. So, that's why in your discharge instructions, you have to include the specific dosage, route, action, and adverse effects of the medication. Patients on aminophylline should have blood level drawn as ordered by the physician. Before being discharged from the hospital, the patient should demonstrate the proper use of metered dose inhalers. Kay bang hindi rin maaram. Okay? Kay walay mo gintutduan, di gin inhale nga tanan. Alright? So na overdose na ngayon. Right? And then complications. Instruct patients to notify their primary healthcare provider of any change in the color or consistency of their secretion. So green colored secretions may indicate the presence of respiratory infection. Patients should also report consistent, prolonged periods of dyspnea that are unrelieved by medications. Okay? So, follow up. Okay? Consider that patients with severe disease may need assistance with activities of daily living after discharge. Note any referral to social services. Send patients home with a diet provided by the dietitian and reinforced by the nurse, which provides a high caloric intake. Encourage the patient to cover the face with a scarf if he or she goes out of doors in the winter. Kung may winter, kita didi waray man winter, so mag-jacket na la kung matugnaw. Okay, because there are really people who have their lungs are weak. Okay, so if the patient continues to smoke, provide the name of a smoking cessation program or a support group. Encourage the patient to avoid irritants in the air. Okay, so our actually having COVID somehow has been a blessing because everybody has taken good care of their health. Everybody has been conscious and aware how to wear a mask, how to wear a face shield. Na, life pala is very important. Okay, so they become um, conscious on what to do. Okay, on their own. Okay? Because we wanted our patients to be independent. Okay, so as simple as irritants could already cause a respiratory syndrome or distress to your lungs. Okay, so next, asthma. Okay, so asthma class. No? We always say about asthma. Okay, we always talk about asthma, but we don't really know, okay, what asthma is all about. All right. So you are a nurse, so you should know what asthma is. Okay. So asthma is the bronchoconstriction results in dyspnea, wheezing, and coughing. Okay. In other words, hubak. Okay. So this is the normal bronchial tube. Okay, amo ini ang normal nga bronchial tube. Now, this is the relaxed smooth muscles. Okay, ito. And then these are the alveoli. Okay, so kung normal bronchial tube, yan. This is the daanan ng air, blood na may air, oxygenated blood. Okay? However, okay, pag nag-swell yan, nag-swell, humubag, tapos may mucus pa hailarong, okay, nagtatighten ang imo smooth muscle. So, kung nagtatighten niya, parang, parang pinipihit niya yung, ano mo, yung daanan ng dugo or daanan ng air sa lungs. So, parang kinukumot niya ba? Yan. So, all the more no na nagkaka-difficulty of breathing. Kasi lumiliit pa yung daanan ng air, may mucus pa sa ilalim, okay? Nag-inflame pa. Right. So, asthma. Asthma is a chronic inflammatory disease of the airways characterized by hyperresponsiveness, mucosal edema, and mucus production. This inflammation ultimately leads to recurrent episodes of asthma symptoms. So, when we say recurrent, pabalik-balik in asthma. If you were born asthmatic, until ka lumaki, asthmatic ka pa rin because you will be triggered by pollen grain, by dust. So, pabalik-balik ang imong cough, pabalik-balik ang imong hubak. So, there would be chest tightness, wheezing, and dyspnea. So, patients with asthma may experience symptom-free periods alternating with acute exacerbations that last from minutes to hours or days. So, asthma, the most common chronic disease of childhood, can begin at any stage or at any age. Alright, so what are the causes of asthma? So the main triggers of asthma are allergies. Okay, so you have to be careful, especially if school nurse ka, tapos may da ka mga estudyante or mga pupil na asthmatic, and then as simple as pain, okay, it can already trigger asthma. Okay, and asthma attacks are very quick. And there are a lot of children who died because of asthma. So asthma is not as simple as we think it is. So viral infections, autonomic nervous system imbalances that can cause an increase in parasympathetic stimulation, medication, psychological factors, and exercise of asthmatic conditions in patients under 30 years old. 70% are caused by allergies. Okay, so three major indoor allergens are dust mites, cockroaches, and cats. So, kaya nga pag may mga asthmatic na bata, if you have a brother or sister or a future child which is asthmatic, please maglinis-linis pag may time. Um, Avoid having cats in the house, having dogs in the house, and then cockroaches. And then in older patients, the cause is almost always non-allergic types of irritants such as smog, and then heredity plays a part in about 1/3 of the cases. Okay, so an asthma attack may occur spontaneously or in response to a trigger. Either way, the attack progresses in the following manner. So there is an initial release of inflammatory mediators from bronchial mast cells, epithelial cells, and macrophages, followed by activation of other inflammatory cells. So nag-i-inflame na. Lumalabas ang mga inflammatory mediators. And then alteration of autonomic neural control of airway tone and epithelial integrity occur, and the increased responsiveness in airways smooth muscle results in clinical manifestations such as wheezing and dyspnea. Okay, so there are three events that contribute to clinical manifestation: nagkaka-bronchial spasm, inflammation and edema of the mucosa, and then production of thick mucus, which results in increased airway resistance, premature closure of airways, hyperinflation, increased work of breathing, and impaired gas exchange. So if not treated promptly, status asthmaticus, an acute, severe, prolonged asthma attack that is unresponsive to the usual treatment may occur, requiring hospitalization. Okay, so this is the mechanism of asthma. Okay, so triggers, offending antigen. Okay, so the triggers are the dust mites, the dogs, the cats, the pollen grains, offending antigen, mediators, dendritic cell, T cell response, and then stimulation of interleukins, IgE, and interferon, activation of your mast cells and eosinophils, and then histamines, prostaglandins, and leukotrienes. Kasi once there is an allergic reaction of the body, your histamine will rise. Okay? So, nagkakaroon ng inflammation. Just as the usual allergy that you have. So, pag nag-increase ang histamine, nag-i-inflame. Now, ang nag-i-inflame is not just the skin of our bodies, but ang nag-i-inflame ang bronchioles or the lung airway. Okay? So, mahirap yun kasi doon sa ilalim ang allergic reaction. So, mechanisms of airway narrowing. So, airway smooth muscle responds to bronchoconstrictor, and then airway edema, inflammatory mediators, microvascular leakage, and airway thickening. Okay, so remodeling. And then we have the cholinergic nerves activated by reflex triggers and bronchoconstriction. Okay. So then, pag nag-bronchoconstriction na, meron na tayong airway hyperresponsiveness, mucus hypersecretion, airway narrowing, and bronchospasm, and then symptoms, wheezing, and then shortness of breath. Okay? So we have classification of asthma. So we have the extrinsic asthma or the atopic allergic asthma. So our immune system overreacts to these often harmless items, forming antibodies which are normally used to attack viruses or bacteria. So mast cells release these antibodies as well as the chemicals to defend the body. So antigen, okay, or allergen. So pagpasok ng allergen sa katawan mo, your body will form antibodies, okay, para mag-fight ha virus or ha bacteria. Okay, so extrinsic, from the word extrinsic, outside Okay, so an allergen from the outside, a foreign material came inside our bodies. Okay, and then common irritants, cockroach particles, cat hair and saliva, dog hair and saliva, house dust mites, mold or yeast spores, metabisulfite used as a preservative in many beverages and some foods, and then pollen. So when you have or when you interview a patient with asthma, you would ask, Ma'am, may pusa ba iyo? Or may aso ba iyo? Okay? Or may molds? Not really. You'd really not ask if they have molds in their houses. But, you would be asking if the child or the person with asthma was exposed to allergens. Okay? So intrinsic asthma, okay, cold non-allergic asthma is not allergic related, and in fact it is caused by anything except an allergy. So smoke, aspirin, chest infection, stress. Okay, may mga nagkaka-asthma dahil sa stress. And then, laughter din, exercise, cold air, food preservatives, or a myriad of other factors. So just read those intrinsic asthma factors. Okay? So clinical manifestation. So these are the clinical manifestations. So paki-review na lang. Okay. So an asthma exacerbation is frequently preceded by increasing symptoms over days, but it may be benign, but it may begin abruptly. Okay, so chest tightness and dyspnea occur. Okay, so expiration requires efforts and becomes prolonged. So if you have seen a person with asthma, you can just see that they have prolonged expiration, and sometimes my wheezing pa or crackles. Okay, all right. So just read about the clinical manifestations for review. And then primary nursing diagnosis, ineffective airway clearance related to obstruction from narrow lumen and thick mucus secondary to asthma as evidenced by production of thick mucus. Okay? So outcomes, respiratory status, gas exchange, respiratory status, ventilation, symptoms, control behavior, treatment behavior, illness or injury, and then comfort level. So interventions, airway management, anxiety reduction, oxygen therapy, airway suctioning, airway insertion and stabilization, cough enhancement, mechanical ventilation, positioning, and respiratory monitoring. So it is a case-to-case basis class. Okay, so just um, you know, slowly but surely, you are listing down the intervention so you would know na what to do. Okay? Dili ka na mahihirapan. So, amoy niya. Alright? So, it takes time, but experience, no? Through experience, you will also become an expert in the nearest future. Okay? Sa, the hard things is when we start, but once we know the basics already, everything will follow. All right. So assessment and diagnostic methods, so family, environment, and occupational history are essential. So spirometry will detect, you already had that, the inspiratory capacity, the tidal volume. All right. So symptoms, 2 times per week, pag mild intermittent asthma, brief exacerbations, and then nighttime symptoms, so 2 times a month, and then asymptomatic in normal peak expiratory flow. Okay? And then we have the mild persistent asthma, right? Paki-review na lang. And then moderate persistent asthma. So daily symptoms, exacerbations, nighttime symptoms. So pabalik-balik na lang yan. Alright, and then we have the severe persistent asthma. Talagang frequent na siya. Alright? So medical management. Okay? So medications. Nursing management. So always assess for patient's respiratory status, by monitoring the severity of symptoms, breath sounds, peak flow, and pulse oximetry, and vital signs. Okay? Obtain a history of allergic reactions to medications before administering medications and identify medications the patient is currently taking. So, ayaw paghikalimot, may asthma na nga ni, di ba? Pakiana kung allergic bahiya, antibiotic, pakiana kung allergic bahiya, haim mga medications nga ihahatag. Kay kung allergic hiya, diri naton ihahatag. Okay? These things are life-threatening. Okay? Pila lang ba ang pagpakiana kung allergic ba o diri? Okay? Alright, pharmacologic intervention, so bronchodilator, and then nursing intervention encourage mobilization of secretion through ambulation, coughing, and deep breathing. Ensure adequate fluid intake to liquefy secretions and prevent dehydration caused by fever and tachypnea. And then encourage rest, avoidance of bronchial irritant, and a good diet to facilitate recovery. And instruct the patient to complete the full course of prescribed antibiotics and explain the effect of meals on drug absorption. Kasi minsan tayo like, 3 days la, okay, di tinatapos ang 7 days. Now, the bacteria or the viruses inside the body will become antibiotic resistant. So, mas malaking problema. When it says 7 days, finish the 7 days. Okay, so administer medications as prescribed. Alright. So, and administer fluids if the patient is dehydrated. Assist with intubation procedure if required. Okay, so just read about the teaching points. What things will you teach? Like the peak flow monitoring if they have to. Okay, and then, yun. Obtain current educational materials for the patient. So, in the duty, you can prepare a pamphlet for your case presentation or your health teaching because magagamit din ng pasyente mo. Okay, so your patient's diagnosis, the causative factors, the educational level, and culture background. Okay, and then continuous care, so mga home health teaching. Alright, so you will be teaching strategies and then documentation guidelines. So document the RR, the breath sounds, the use of oxygen, color of nail beds and the lips, and then note any respiratory distress and the degree of shortness of breath and the degree of fatigue. Kasi makapoy iton ko may hubak. And then comfort, body temperature, response to medications, oxygen and breathing treatments, and need for assistance with activities of daily living, and response to diet and increased caloric intake in the daily weights. Right, and then respiratory status, patency of airway, auscultation of the lungs, presence or absence of adventitious breath sounds, respiratory rate, and depth. Okay, so response to medications, oxygen therapy, hydration, and bed rest. Alright, so kamo, ayaw ka mo wag kayong matakot ng pasyente, no? Kung hindi lang sana COVID time ngayon, it's very good to go to the medical ward kasi you will learn so much. Iba kasi class ang nakita mo talaga. Iba din yung sa theory lang. Okay? So, wag kayong matakot mag-auscultate. No? Kaya nga may pasyente, kaya nga tayo nag-aaral, so you would know ito pala. Especially those na magme-medicine, nursing pa lang, dapat gamay mo na yan, o dapat magaling ka na dyan, para konting na lang, no? Konting adjustment na lang on your higher education. Okay? So, wag matakot, mag-auscultate, makinig. Alright? And then, status epilepticus. Okay, so that is an inhaler class. So, inhaler device, spacer, if you are, sa asthmatic pala, bawal din minsan yung mga, hindi lang minsan, no, but bawal, most of them are bawal with chicken, okay, and any foods high on histamine. Alright, and this is the spacer, and then the lungs, the air sacs, okay. So, ang status asthmaticus class, it is a severe and persistent asthma that does not respond to conventional therapy. Attacks can occur with little or no warning and can progress rapidly to asphyxiation. So, infection anxiety, nebulizer abuse, dehydration, increased adrenergic blockage, and non-specific irritants may contribute to these episodes. So an acute episode may be precipitated by hypersensitivity to aspirin. So two predominant pathologic problems occur: a decrease in bronchial diameter and a ventilation and then perfusion abnormality. Okay, so pathophysiology, we already discussed that. Okay, so you can watch videos in YouTube if you have time or if you have a stronger internet connection, and you can read this one. Okay, so if only we had the time to make a diagram, that would be better. All right, and then assessment and diagnostic findings, so ABG analysis, and then nursing alert, rising PaCO2 to normal or higher is a danger sign. So would signal a respiratory failure. Amo, if the PaCO2 class in the laboratory results, okay, is higher than the normal, if there is a deviation, report. Report the doctor, clarify, kasi baka mag-distress ang pasyente. Okay? So, medical management. Okay. Just read kung ano ang mga gamot. So, magnesium sulfate, a calcium antagonist may be administered to induce smooth muscle relaxation. So, I believe that you already had this in pharma. So, have some review. Okay, and then pharmacologic intervention. Okay, so a course of oral antibiotics such as macrolide may be instituted but is controversial. So inhaled bronchodilators to reduce bronchospasm and promote sputum expectoration. Okay, so nursing intervention. So encourage mobilization and secretion through ambulation, coughing, and deep breathing. Okay, para um, mag mag what we call this, mag-loosen, no, ang mga sputum inside. So we have to ambulate, we have to walk, we have to exercise, and then ensure adequate fluid intake to liquefy secretions and prevent dehydration caused by fever and tachypnea, and then encourage rest, avoidance of bronchial irritant, and a good diet to facilitate recovery, and instruct the patient to complete the full course of prescribed antibiotics and explain the effect of meals on drug absorption. Kasi minsan, no, instead of assisting our patients to wellness, hindi mo sinabihan na um, the medications could cause thinning of the gastric lining. Okay? So, nagkaka-ulcer ang iya gastric lining kasi may mga gamot na with high efficacy and nakakasira ng ano, nakakasira ng gastric lining. So, there are medications, so you have to read, no, the instructions for the medications if kailangan kumain muna 30 minutes or an hour before the medications will be given. Okay? So, these are the nursing interventions. Okay, pabalik-balik na tayo sa nursing interventions. Alright? So, constantly monitor the patient for the first 12 to 24 hours or until status asthmaticus is under control. Okay, then BP, cardiac rhythm. Alright. So, assess the patient's skin turgor for signs of dehydration. So, malalaman mo naman pag ganun pa sa skin turgor, dehydrated, no? It doesn't go back quickly. Then fluid intake is essential to combat dehydration or to loosen secretions or to facilitate expectoration. And then administer IV fluids as prescribed up to 3 to 4 liters per day unless contraindicated. And then encourage the patient to conserve energy. This is very challenging kung bata ang pasyente, no? And then ensure patient's room is quiet and free of respiratory irritants. So, itong mga visitors, please lang, signa, ha? And may mga asthma, bawal hin flowers, bawal hin magsigarilyo, bawal hin perfumes or odors of cleaning agents, mga Zonrox, mga Domex, and non-allergenic pillows should be used kasi nakaka-trigger and, asthma attack. Alright. So, discharge and home healthcare guidelines. So, follow up. Okay. So, send patients home, provided by the dietitian and reinforced by the nurse. As a nurse, ikaw talaga yung frontliner. Okay. So, you have to provide a high caloric intake, encourage the patient to cover the face with the scarf. So, you really have to be specific class on your health teaching or your discharge instructions, being a negligent ba, no? Or being, you know, under negligence or being neglectful. Okay la ito class di diha Pilipinas. Diri ito okay ha iba nga nasod kay pwede kita kasubhan. Okay? And patients are also very legally conscious. Okay? They are also knowledgeable. They are educated. So, gawin mo yung trabaho mo ng mabuti. Okay? Okay. Cystic fibrosis. So, cystic fibrosis is a hereditary disorder characterized by lung congestion and infection as malabsorption of nutrients by the pancreas. Okay? So, doon sa lungs, no? Sa lungs nagko-congestion. And this is the pancreas. So, kawawa naman yung bata. Alright? So, this is cystic fibrosis. We're almost done. Okay, so that is the description. It is an autosomal recessive disorder affecting the exocrine glands in which the secretions become abnormally viscous and liable to obstruct glandular ducts. It primarily affects pulmonary and GI function. The average life expectancy for the cystic fibrosis patient is currently age 32, 40. So death may occur because of respiratory infection and failure. So pakibasa na lang ng mga complications: esophageal varices, diabetes, chronic sinusitis, pancreatitis, rectal polyps, intussusceptions, growth retardation, and infertility. Okay, and then ito yung cause. So the responsible gene, the CF transmembrane conductance regulator, or the CFTR, is mapped to chromosome 7. You can see the genetic considerations. The underlying defect of this autosomal recessive condition involves a defective protein that interferes with chloride transport, which in turn makes the body secretions very thick and tenacious. The ducts of the exocrine gland subsequently become obstructed. Okay, so assessment usually present before age 6 months, but severity varies and may present later. Meconium ileus is found in neonate. Okay, so usually, you know what a meconium is, right? So usually present with respiratory symptoms, chronic cough, and wheezing, and parents may report salty taste when skin is kissed. So recurrent pulmonary infections, failure to gain weight or grow in the presence of a good appetite. Alright, and assessment, pakibasa. So, ang pinaka-importante class na i-remember mo sa cystic fibrosis is the clubbing of fingers. I think you know what clubbing of fingers is. And then protuberant abdomen. Siyempre, malaki kasi nasa pancreas yung infection. And then pot belly, wasted buttocks, and then bleeding disorders, increased anteroposterior chest diameter or barrel chest, decreased exertional endurance, hyperglycemia, glucosuria with polyuria, and weight loss, and sterility in males. Okay? Then excessive fetus, so on and so forth. And then steatorrhea, foul-smelling stools. Okay? So, diagnostic evaluation, paki-review na lang. Okay, diagnostic evaluation, basta one of the most important diagnostic evaluation would be the chest x-ray. Okay, and then some other pulmonary function studies. Alright, so primary diagnosis: ineffective airway clearance related to excess tenacious mucus, secondary to status asthmaticus as evidenced by increased mucus production. Okay? So, therapeutic intervention or medical management, flu vaccine, pneumococcal polysaccharide vaccine, lung transplant if possible, oxygen therapy, antibiotics, okay, any treatment to infections. And then special diet, high in protein and calories of older children and adults, and then pancreatic enzymes to help absorb fats and protein kasi sira na nga yung pancreas. Alright? And then vitamin supplements, especially the vitamins ADEK, and then your doctor can suggest other treatments if you have very hard stools. Okay, so kawawa naman. And then pharmacologic intervention, pakibasa na lang. So bronchodilators, again, increase airway size and assist in mucus clearance. Okay, so pharmacologic intervention, alright. So nursing interventions, okay, pakibasa na lang yan. Help the child to relax to cough more easily after positional drainage, and then suction the infant or young child when necessary if not able to cough. Okay, so more on the nutrition part, the respiratory care measures, promote airway clearance, employ intermittent aerosol therapy. Okay, so teach the child breathing exercises using pursed lips to increase duration of exhalation, and then provide good skincare and position changes to prevent skin breakdown in malnourished child. Okay, so restrict contact with people with respiratory infection kasi they are very prone to getting sick, okay? Immunocompromised na nga, di ba? Madali lang sila magka-infection. And of course, encourage diet composed of foods high in calories and protein and moderate to high in fat because absorption of food is incomplete. So, hindi rin naman na-absorb. Okay, so pakibasa na lang ng mga nursing intervention. Just don't forget that in cystic fibrosis, administer fat-soluble vitamins as prescribed to counteract malabsorption. Kasi kahit gaano kadaming pagkain ang ipakain mo, sira na ang pancreas. So, there is malabsorption of food. So then, ADEC is administered just to help the body absorb some nutrients. Okay, so increase salt intake during hot weather, fever, or excessive exercise to prevent sodium depletion and cardiovascular compromise. So to prevent vomiting, allow ample time for feeding because of irritability if not feeling well and coughing. So ayaw pagdagmit. Okay, feed them. Dapat yung timing. And then kasi or else magsusuka yan. And then encourage regular exercise and activity to foster sense of accomplishment and independence and improve pulmonary function. So provide opportunities for parents to learn all aspects of care for the child and teach the parents about dietary regimen and special need for calories, fat, and vitamins. Okay, so turuan, okay, health teaching class is very important. And discuss need for salt replacement, especially on hot summer days or when fever, vomiting, and diarrhea occur. Okay, so documentation, so physical response, color, odor, character of mucus, cardiac and GI assessment, pulse oximetry, nutritional data, weight, use of enzymes, adherence to supplemental feedings, emotional response, is the child irritated or irritable, patient's feelings about dealing with a chronic illness, patient's body image, di ba? Ikaw daw, malaki ang tiyan mo, di ba? So, tapos tutuksohin ka pa ng ibang mga bata. And then parents' coping ability and siblings' response. Kasi hindi madali ang magkaroon ng anak na may sakit. Alright? And then respiratory status of the patient. So RR, oxygen, color of nail beds and lips, and then response to activity. So degree of shortness of breath, and any exertion, degree of fatigue, comfort, body temperature, so on and so forth. Okay, so discharge and home healthcare guidelines. So just the same, okay? Always educate the parents on the need to keep the routine follow-up appointment. So if any untoward reactions is there, especially if there are the signs and symptoms, of pneumonia, okay, there is sputum production. So, magpa-check up agad. And then, the child should be kept away from any children with common colds and nasopharyngitis. Kasi, di ba, meron na nga siyang cystic fibrosis, makakalaro pa niya may sipon, mas lalo siyang magkakasakit. Alright? So, okay. Alright. So, we are done. Okay, so I am hoping, no, Ruby, that you are learning something and you will take the junior level seriously. Okay, especially the medical surgical concepts. Your NCM is very important. Your NCM is now starting to really get serious. Welcome to the nursing world proper. So you are expected to act like a nurse, to act professionally, to bring with you your knowledge, your health teachings, your ideas in pathophysiology. You are now begin We are now beginning to um, see, no, if you have what it takes to become RNs of the Republic of the Philippines. So, um, do not be afraid. Learn as much as you can, okay, and enjoy learning, okay. So I wish you all a great day and a great weekend. Okay, just signify if you have watched the video, and God bless on your exams, and study, no? Study, 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 study every day. Do not forget what you have learned, and someday all things will make sense. Okay, so see you around, people, and I wish you all the best, hoping that you will not fail on any minor or major subject. Okay, and we will top the board exam and pass 100%. Okay, keep the goal in mind always. Stay safe, stay healthy. Blessings everybody, that the good Lord will always provide for our needs and always give us a life that is healthy, and a life that is ready to serve our patients. To be a nurse is such a great blessing. And one day, you'd realize that what you know now and what you are still to learn will be helpful, so that you will have a productive career, and you will really maximize your nursing career. Okay? So, bye for now, people. God bless.